Okay, welcome to Neuro, Psych, Pharmacology 3. We have 3 topics in this section. Parkinson's disease agents, Alzheimer's disease agents, and anti-epileptic agents. The first Parkinson's disease agent we'll talk about is levodopa, carbidopa, and selegiline. So how these work is we have to kind of go back to the Parkinson's disease pathology. In the substantia nigra, we have an accelerator and brake pedal for the motor cortex of the brain. So dopamine is the accelerator, GABA, a neurotransmitter, is a brake. So the normal dopaminergic neuron, it releases dopamine, and then the GABAergic neuron releases GABA. Okay? And when that happens that way, then we get smooth movement, green light, everything's working fine. But with the pathology that comes along with Parkinson's disease, we get low dopamine and elevated acetylcholine. And then if that's the case, then we're going to see that the movement is not smooth, that the body is very jerky, and we're going to see some very specific movements that go along with Parkinson's. So Parkinson's disease presents as postural impairment. It's difficult to maintain straight posture. Tremors, rigidity of the limbs and the body. And then just like bradycardia is a slow heartbeat, bradycardia is less than 60 beats per minute. Bradykinesia, just like kinesiology is a kinesiology majors in the study of movement. Bradykinesia is a very slow movement. There's feet shuffling. But it's very distinctive, the Parkinson's presentation. The treatment or the goal is to restore dopamine levels in the brain, but it's not as simple as just saying, okay, well, we'll just put some dopamine in their brain. The problem is that dopamine does not cross the blood-brain barrier, the BBB or triple B. As we grow or as we're born, our blood-brain barrier protects us from many different toxic substances. But unfortunately, with many neurodrugs, it actually prevents something that could really help us from getting there. So the solution is to give a dopamine precursor that does cross the blood-brain barrier. And that precursor is called levodopa. It's also known as L-dopa. All Parkinson's disease patients eventually require levodopa. It crosses the blood-brain barrier, no problem, and it's converted to dopamine in the brain. We have a second problem, though, in that it converts to dopamine in the peripheral tissues before it even gets to the brain by an enzyme called dopa decarboxylase. And this is kind of a deal breaker. Until we add dopa decarboxylase inhibitor to stop the conversion. That's called carbidopa. So carbidopa is the dopa decarboxylase inhibitor blocking the enzyme in a little bit of a different way. It's structurally really similar to levodopa. And because of that, it kind of distracts the enzyme to target carbidopa instead of levodopa. So it's like over here, and then levodopa makes it to the finish line, makes it to the brain. So what we have is this combination, levodopa, carbidopa, Sinemet. We adjust the dose based on the symptom response, and then over time, patients will report on and off as the response diminishes. On is the medication working, we've got good movement. Off, the medication is not working, we've got tremors, rigidity, slowness returns. It should not be given to those with psychosis of any kind because what we're doing is we're adding dopamine, and this could be a really bad thing if someone has psychoses. It takes months to see full effects, and then there could be a hypertensive crisis if given with non-selective MAOIs. So those are the 3 caveats to watch out for with carbidopa or levodopa carbidopa. Another drug that we can use is selegiline, and in the brand name you can see L-Dipril, and they were going for elderly, that many elderly find this Parkinson's disease something that they have. And monoamine oxidase B, it's a monoamine oxidase B inhibitor, and the A isomer of the enzyme breaks down norepinephrine, serotonin, or 5-HT, and dopamine. The B isomer breaks down dopamine selectively. So it slows the breakdown of this dopamine in the brain, and it allows for lower doses of levodopa. So two different ways of approaching Parkinson's disease. In both cases, we want to make sure we can get more dopamine in the brain. It should not be given alone, and levodopa, carbidopa must also be given to be effective in Parkinson's disease. Alzheimer's disease agents. So we're just going to talk about two of them, donepezil and memantine. The thing about Alzheimer's disease is you can never really know until after someone has passed if the person had Alzheimer's disease. You have to actually look at their brain and see, okay, well, this is what we're seeing, and we'll see what the pathology looks like in the next slide. But the exact cause, we still don't know. There's some anomalies or things wrong within the hippocampus. The current treatments can slow disease progression, but there's no cure yet. And diagnosis to death can occur in 4 to 8 years, or it could be a bit longer. It depends on who you're reading. Symptoms. A lot of times we think just about the memory loss in Alzheimer's, and that is certainly one of the things that happens with it, but there's also impaired thinking. There's a cognitive decline, and then inability to perform activities of daily living. So it's extremely hard on the patient, certainly, but it's also extremely hard on the partner or caregiver as well. The pathology, so we have this neuron, and we're going to have these amyloid plaques, which is a hallmark anatomy of Alzheimer's, decreased acetylcholine levels, these deformed microtubules, and the neurons are just kind of a mess. Okay, so what can we do with it? Well, two classes of medications we'll talk about are cholinesterase inhibitors and NMDA receptor antagonists. So the first thing we'll talk about is how a cholinesterase inhibitor works. Much like Parkinson's, where we can't just give dopamine, we can't just give acetylcholine. So instead of giving acetylcholine, donepezil, brand Aricept, which is for mild to moderate symptoms, it prevents the breakdown of acetylcholine, which is a common neurotransmitter. And by preventing the breakdown, what we do is allow more acetylcholine to be around. The thing is that if you allow more acetylcholine to be around, you're going to see that we're going to have cholinergic adverse drug reactions. We're going to see maybe nausea, vomiting, diarrhea, some dyspepsia as some of the side effects. And as you can see in the graphic, it's only effective for 1 in 12 patients. So not the best prognosis for a medication. Another drug, memantine or Namenda, is an NMDA receptor antagonist, and you can see the N, the M, the D, and the A in the brand name Namenda. And it regulates calcium levels in the neurons by binding to these NMDA receptors. So high calcium in the neurons is implicit for Alzheimer's disease. We have decreased learning and memory ability, neuron degradation. Regulated calcium in the neurons, increased or normalized learning and memory ability, increased neuron lifespan. But those are the two Alzheimer's disease medications. Anti-epileptic agents, we're going to first talk a little bit about epilepsy itself, kind of just a very big view of some of the conditions that someone can have, and then we'll talk about the two divisions of the anti-epileptic agents. So epilepsy is a chronic seizure condition. We have hyperexcitability of the neurons in the brain, and 70% of the time it's idiopathic. We have no idea what's going on. Maybe genetic CNS abnormalities, but we need chronic treatment with medications. So these are for partial focal, simple and complex, generalized, tonic-clonic, absence, myoclonic, febrile or fever seizures, and status epilepticus. Secondary or symptomatic are caused by illnesses, and so a temporary anti-epileptic treatment is needed until the underlying cause is corrected. So these seizures can happen it's really figuring out, is it the illness that's causing it, or is it something that we're just not sure about? But really, the anti-epileptic treatment for each type is pretty much the same. And a term that I want you to know, though, is that the seizure focus, that's where the beginning of the seizure is. So in terms of the anti-epileptic agents, they decrease neuronal activity during the seizure focus. They slow or stop the spread of the seizure from the focus to other areas of the brain. But there's these two terms that we want to make sure we're clear about. A seizure is any type of epileptic event, whereas a convulsion, it's just an abnormal motor phenomena. So these are just a little bit different. But let's look at some of the medications that we can use. So as far as the older medications, carbamazepine is one of them, and it inhibits sodium channels on hyperactive neurons, and it prevents sodium from entering the neuron, and it stops the action potential. But we have serious adverse drug reactions, including bone marrow suppression, it's teratogenic, and grapefruit juice can increase levels. Divalproex, or Depakote, works in three ways. It inhibits sodium channels on the hyperactive neurons, just like carbamazepine. It inhibits calcium influx into the neurons, and it promotes GABA activity and release. But there's some serious adverse drug reactions in hepatic and pancreatic toxicities, teratogenicity, and then it would interact with phenytoin, the third of the traditional anti-epileptics we'll talk about. Phenytoin, or Dilantin, it inhibits sodium channels on the hyperactive neurons. It prevents sodium from entering the neuron, stopping the action potential, same as carbamazepine, but it requires lots of monitoring. Small dose increases can cause toxicities, and small dose increases can cause therapy failure, or decreases can cause therapy failure. So what we want to do is we want to make sure that we're monitoring appropriately, but we want to make sure that with phenytoin especially, that we're keeping it at the right levels. And then two of the newer, just to give you some examples, there are many of the newer anti-epileptics. Gabapentin, which is Neurontin, and pregabalin, which is Lyrica. Pregabalin happens to be the metabolite of gabapentin, and both work as adjunct therapy for epilepsies. But common adverse drug reactions, drowsiness, blurry vision, peripheral edema. But that's really how you want to divide them. The older drugs, which we know quite a bit about, have a lot more history. And then the newer drugs may have a little bit less in the adverse drug reactions, but we're not necessarily as confident sometimes with the newer ones in terms of what we know about which seizures they work for.